Good afternoon, everyone. We good to go? Great. Good afternoon, everyone. I'm Lisa McGovern, Executive Director of the Congressional Families Cancer Prevention Program of the Prevent Cancer Foundation. I want to thank each and every one of you for joining us today for this important conversation on understanding breast cancer screening guidelines and overcoming disparities. It's a crazy busy time for everyone right now, and certainly on the Hill. So we're really grateful to the more than 130 Congressional Families members and staff and Hill staff that are joining us today. For those of you who aren't familiar with our program, the Congressional Families Program since 1991 has worked to educate the public and to empower individuals and communities across the nation to take steps to reduce cancer risk. We are a bipartisan group of congressional spouses. Cancer knows no political party. We've all been affected by these terrible diseases. And I'm proud to say that this year marks our 30th anniversary of working across the aisle and across the country to fight cancer through education and outreach. The Congressional Families Program offers trusted information on the latest in cancer prevention and early detection, as well as resources for members and spouses to use, such as op-eds, social media posts, and support for in-district events. We also offer seminars and webinars, such as this one. If you are representing your boss's office and would like additional information about our program, yes, Hill staffers, I'm looking at you, please reach out. We'd love to work with you and offer ready-to-go resources to use in your districts and states. Before we begin, I want to offer our sincere thanks to our generous sponsors, Bristol-Myers Squibb, Grail, Garden, Hologic, the National Association of Broadcasters, and Oracle. You have stood by us through this pandemic and helped us reach this 30th anniversary bipartisan milestone. Thank you for making our work possible. Now, I'd like to introduce our moderator for today's program, my very dear friend, Lacey Schwartz Delgado. Lacey is an Emmy-nominated producer, writer, and director who creates compelling stories that span documentary and fiction. She is also the co-founder of Truth Aid, a production company producing multimedia content to affect social change. Lacey is a professional powerhouse who manages a demanding career, 8-year-old twins, and life as a congressional spouse. She is married to Representative Antonio Delgado of New York. And Lacey also serves as the trusted treasurer of the Congressional Club, who we were founded in partnership with. So thank you so much, Lacey, for taking time out of your very busy schedule to join us today. And now it's my pleasure to turn the program over to you.
Thank you, Lisa, for that kind introduction. I'm so grateful to be here today with the Congressional Families Program for such an important topic. This month, as many of you know, is Breast Cancer Awareness Month, but this conversation would be just as relevant any time of year. 1 in 8 women in the United States will be diagnosed with breast cancer in their lifetime. Breast cancer screening saves lives. Mammograms are an effective tool, but there remains a great deal of confusion among many women about when screening should begin and how often to be screened. A recent Prevent Cancer Foundation survey found that 42% of women don't know how often they should be screened for breast cancer. The numbers are even higher for younger women and women of color. We hope today's discussion will leave you with a clear understanding about breast cancer screening. We'll also address the important issue of the burden that Black women face when it comes to the disease. Although Black women face similar risk as white women in being diagnosed with breast cancer, they are more likely to die of the disease. Why does this disparity exist, and how can we overcome it? Our speakers will address this issue, and we'll hear from one organization that has made significant progress in its community. There will also be time for Q&A following today's speakers, so please put your questions in the Q&A box at the bottom of the screen, and we will get to those as time allows. Before we begin, though, we want to start with a couple of poll questions. Your answers are anonymous, so we'll hope you'll participate and be honest. So You'll see the first on the screen. The first question is, have you missed or postponed any in-person medical appointments and/or test screenings because of the COVID-19 pandemic? Please choose one of these responses. The first one is, yes, I missed or postponed an in-person medical appointment or routine screening during the pandemic and it was rescheduled. Yes, I was due for a medical appointment or routine screening during the pandemic and it has not yet been scheduled. No, I made all in-person medical appointments and routine screenings during the pandemic at their originally scheduled time. And lastly, no, I have not had any in-person medical appointments or routine screenings scheduled or due during the pandemic. So please choose one answer. Okay, and then let's do one more poll. At what age should women at average risk begin annual mammograms? First choice is 40, second choice is 45, third is 50, or last, I have seen varying recommendations and am unsure when annual mammograms should begin. So please choose your answer. Okay, we look forward to coming back to those. Now I'd like to introduce our first speaker, Dr. Richard Wender. Dr. Wender is chair of the Department of Family Medicine and Community Health in the Perelman School of Medicine at the University of Pennsylvania. He has dedicated his career to leading medical and public health efforts that strive to improve the quality of primary care and improve population health. From 2013 to 2020, Dr. Wender served as the first Chief Cancer Control Officer of the American Cancer Society. Throughout his esteemed career, Dr. Wender has continuously advocated for the importance of preventive care and for the creation of an effective bridge between primary care and public health. Thank you, Dr. Wender, for being here today.
Thank you so much, Lacey, and it's really a pleasure to be able to meet with you. Thank you to Prevent Cancer Foundation, Congressional Families Club. It's really an important topic, and I'm just honored to be a part of this discussion. So let me begin. And I have the difficult task, but an important task of talking about guidelines for breast cancer screening. And I want to echo what Lacey said at the beginning. If you look at colorectal, lung, and prostate cancer, there's really no difference between guidelines, and it's allowed us to focus all of our efforts on uptake, on implementation. But the differences in breast cancer screening guidelines really are a source of confusion. And I think as a result, they've become a barrier to encouraging more women to be screened. And so let's see if we can help address that today. Just make sure I didn't miss one. There we go. So there are four, the way I like to look at this is kind of four major groupings of current breast cancer guidelines. And I've picked what I think are the most influential and put the two most important, I think, at the top. So number one is the United States Preventive Services Task Force. The reason that's most important is because coverage for cancer screening guidelines are linked to A and B recommendations of the task force. Although in breast cancer, I have to say coverage is less of an issue. We'll visit that later. So what the task force guideline is shared by the American College of Physicians and the American Academy of Family Physicians. The second major one is the American Cancer Society. That's shared by the American Association of Breast Surgeons. The reason I call out those two guidelines is because they follow a very strict multi-year process with an independent evidence review, public comment period, a very strict evidence process. They receive very high endorsement by groups who rank quality of guidelines. Third is the National Comprehensive Cancer Network. Their guideline is shared by the American College of Radiology, and it's supported by the Prevent Cancer Foundation. And last is the American College of Obstetricians and Gynecologists, which blends the elements of other guidelines. So here are the areas where all the guidelines agree. all women should have the opportunity to start screening at age 40. All women over age 50 should be screened at least every 2 years. And everybody agrees that screening should continue through age 74 and then individualize it from 75 to 84. Unfortunately, the task force and the ACS guidelines are often misportrayed in the press. I just read this morning. The press generally reports that the task force recommends mammography starting at 50, and they leave out the fact that they clearly state women in their 40s should have the opportunity to start. The ACS guideline is often reported as starting at 45, leaving out the period of 40 to 44. Both guidelines clearly state, as does ACOG, that women should have the choice to start screening at 40. So here are the areas where the guidelines disagree. The task force and the American College of Obstetricians and Gynecologists recommend a shared decision from 40 to 49, and then recommend screening no matter what, without a shared decision, just what I call the just do it approach. The American Cancer Society says that women should have the opportunity to make a shared decision from 40 to 44, but starting at 45 should just do it. Don't need to participate in a decision balancing benefits and harms. And NCCN recommends screening at age 40 without shared decision at any age. That slide right here has become the source of a lot of this confusion about when to start. But there is another area of disagreement that needs to be highlighted. The task force recommends every other year screening at every age. The ACS says annual from 40 to 54, which is really a marker for when menopause has occurred in almost all women. And then every 1 or 2 years thereafter, saying that every 2 years is safe and you can transition, but you can continue every year if you prefer. NCCN and ACOG recommend annual from age 40 onward for those women who choose to start screening then. I do believe, and I'm a co-author, so I do have a bit of a bias here, that the American Cancer Society guideline is kind of all-encompassing. It's exquisitely researched. It's received a lot of support in the academic world, that all women should have the choice to start screening at age 40. But if you haven't already started by age 45, that is the date where you absolutely have to start screening. No longer, it shouldn't be viewed as an option. Obviously any woman can opt out, but the recommendation is clear. I think their recommendation for annual screening till 55 is very smart. The breast cancer moves a little bit faster and more aggressively in younger premenopausal women. And then from 55 onward, every other year screening is safe, but for women with dense breast, family history, or just who prefer to get screened every year, they can continue. It's a complex guideline, but I think it's a very all-encompassing and very well-supported guideline. Oh, now it's not advancing. There we go. So this is a complex, I won't spend too much time on it. Just to say that recommending the age to start screening is really difficult. It's a tricky thing to figure out. And the answer is, the risk of breast cancer increases with each year of advancing age. And you can see that when a woman progresses from age 39 to age 40, her incident rate per 100,000 does go up. But there's a pretty big gap between your risk at 40 and your risk at 45. 106 per 100,000 at 40, 166 per 100,000 at 45. And so this is the age where the ACS recommends a shared decision. And you have to realize that if you get screened at 40, 1 in 5 women out of 10,000, that's 1,600 to 2,000 out of 10,000 women, will have what's initially called an abnormal mammogram and have to come back for more imaging. I think this also helps understand this difficulty of that 40 to 44 period. This is a graphic showing the age of diagnosis, not the age of death, but the age of diagnosis for women who go on to succumb and die from a breast cancer diagnosis. You can see that 5% of deaths were in women diagnosed 35 to 39. That does go up a bit, 40 to 44 to 7%. So that's that kind of in-between period where ACS recommends a shared decision. But many women start screening at 40, very reasonable and good choice for many women, the majority, I think. But you can see that 45 to 49 looks a lot like that 50 to 54-year-old group. And that's why ACS thinks that waiting till 50 to just recommend screening for everyone is a little too late. It's important to realize that COVID-19 really interrupted screening. This was a recent study just from a few months ago, looking at one center and what their experience is, but I think it reflects the whole nation. That blue line is what happened to mammography in 2020, and there was a near total disruption. But the interesting thing is that it rapidly returned to a normal screening level. So this just went on for a few months. So it's a real credit to healthcare facilities that they very quickly learned how to bring women in for mammographies and to perform it very, very safely. But here's the problem. Even though there was just a few months of near total disruption, if you look at the mammography rates for the entire year in the blue line, they still fell short of screening in 2019. So we got it back up to the pre-COVID level, but we didn't do enough mammographies to make up for the ones we missed. And there are some women who just were scared to come in and still have not come back in. The NCI, this was quite a few months ago, did an analysis of how many cancer deaths might occur because of this delay in screening. And you can see in the light blue line that there are thousands of breast cancer deaths over the next decades or so that may occur because of this delay in screening. So we really needed to do a good job and get back to what we were doing. So what is the path forward? Mammography is the most widely evaluated cancer screening test in the world. Women 40 and over who participate in regular screening have at least a 40% lower risk of dying from breast cancer. All women should be regularly screened for breast cancer, and all women should consider starting screening at age 40. That's the right choice for many women. 45, the very latest date to start. For women who with a family history, women with dense breasts, most African-American women, women who value the opportunity to avoid a premature breast cancer death and are willing to put up with the high risk of an initial abnormal mammogram, often and should start at 40. So thank you so much for allowing me to participate and look forward to the discussion that we'll do together.
Thank you so much, Dr. Wender, for being here today. Our next speaker is Linda Goler Blount. Sorry, Linda, I mispronounced. Linda Goler Blount. Linda is president and CEO of the Black Women's Health Imperative, where she has overseen more than $20 million invested in Black women's health and research, and is responsible for moving the organization forward in its mission to achieve health equity, as well as reproductive justice for Black women. Before joining the Imperative, Linda served as the Vice President of Programmatic Impact for the United Way of Greater Atlanta, where she led the effort to eliminate inequalities in health, income, education, and housing through place and population-based work. Prior to that, Linda was the first ever National Vice President of Health Disparities at the American Cancer Society. Thank you so much for joining us today, Linda.
Thank you, Lacey, so much for that introduction, and thank you to the Prevent Cancer Foundation. This is the Congressional Families Cancer Prevention Program. This is a really important conversation, and I just want to thank Dr. Wender for teeing this up, because he said something that's really important, and that is this is confusing, and this for the average everyday woman who's just trying to take care of her health. This can be, making this decision about screening mammography can be a challenge. So what I want to do is just cover a few slides, a little bit of some data, some epidemiology, kind of have to do that, just to look at disparities. A lot of this information people know, We're looking at the slide of incidence and death. Black women and white women have about the same incidence of breast cancer. Other women of color, the Alaskan Natives, American Indians, Latinas, Asian Pacific Islander women have about the same incidence. And when we look at mortality rates, we see similarities between the American Indian population and Latinas. APIs are a little bit lower, but the statistic that we all know that is that Black women have about a 40% higher death mortality rate from breast cancer as compared to white women. It's interesting, as much as we talk about social determinants of health, that the American Indian breast cancer death rates are as low as they are. And this slide just shows a little bit more about changes in incidence over time. We've seen the incidence rate increase for the Asian Pacific Islander population and Latinas a little bit, kind of up and down for the American Indian, Alaskan Native population. But importantly, it has dropped, incidence has dropped among non-Hispanic white women and increased among non-Hispanic Black women. We don't know exactly why that has happened. The rates are about the same, as I said. So, what we do need to do is obviously more research. There's some theories that I'll talk about in a little bit, but this is where we are right now. So we spent a lot of time looking at sort of recent data, last 5 or 10 years. I did want to take a step back and look at some historical information. I thought it might be important for this audience to look at a much longer time frame. As we can see, early on, in the late 70s and very early 80s, Black women and white women had about the same death rates. Actually, Black women had a little bit lower death rates. And then something happened, and about 1982, things changed. We've made great progress in general at lowering death rates from breast cancer, but as you look at this graph, you can see the gap between white women and Black women hasn't really changed much. So what happened in 1982? We learned how to detect breast cancer and we learned how to treat it. So this gap that we see between Black women and white women simply reflects who got access and who didn't. From 1982 till today, and the fact that the gap is what it is, that Black women die 40 to 42% more than white women, it still reflects who's getting access to early detection and quality treatment and who isn't. Black women are more likely to be treated in lower resource institutions, have inadequate health insurance, not have access to the latest treatments, which can determine what kind of care they get and whether or not they get care and whether or not they complete their therapy. And this slide, I just wanted to point out, shows the difference in breast cancer subtypes by race and ethnicity. And again, there's something that we are familiar with and have heard, and that is Black women have higher rates of triple negative breast cancer. What you see is HR negative, HER2 negative. Depending on who you read, Black women have 2 to 3 times more likely to be diagnosed with triple negative as compared with white women, and they're 30% more likely to die. But I wanted to point this out because if we look at this and just say Black women, that tells one story. If we look at country of origin, when thinking about Black women, we get a different story. So Black women from the Caribbean have a 13% lower risk or lower rates of triple negative breast cancer. And Black women from Eastern Africa have a 46% lower prevalence of triple negative breast cancer. So I want us to be sort of cautious about sort of lumping Black women together because Black women are not a monolithic group and there are some differences that we need to pay attention to. And just to touch a little bit on screening mammography, we see that for women 50 to 74 who've had a mammogram in the last 2 years, generally the rates are about the same. The American Indian, Alaskan Native populations are a little bit lower. This holds true for annual mammograms, although the rates are much lower, usually between about 45 and 50%. But we see the screening rates are the same, and yet for Black and white women, we see very different outcomes. A few years ago, JAMA, the Journal of American Medical Association, had an article that looked at the distribution of cancer by race and ethnicity. And for women under 50, about 30% of the cancers diagnosed in Black women occurred under 50, about 35% among Hispanic women, 33% among Asian women, as compared to 23% among white women. And some statistics suggest that as much as 8% of breast cancers in Black women actually are detectable under the age of 40. And this slide very quickly just shows sort of a geographic look at screening mammography. The top slide, it shows a map of where Black women are likely to get screened more or less than white women. The red area shows where Black women are significantly less likely to be screened as much as white women. Blue, more. Gray is about the same. And the map on the bottom is the same for Hispanic women. The blue shows where Hispanic women are more likely to be screened, and red, Washington, there's something special about Washington. And the rest of the gray area shows where the screening rates are about the same. So what do we know? Black women have detectable breast cancers much younger than white women. I was a co-author on a study that was published earlier this year in the Journal of the American College of Radiology, which found that Black women were less likely to be screened at high-quality facilities. They were less likely to get the superior mammography, 3D mammography. And when they were screened at facilities that offered both 3D and 2D mammography, Black women were still less likely to be offered 3D mammography. And we also know, as I said, that Black women are more likely to be treated in low-resource facilities and not academic medical centers. But interestingly, when we look at care, providers are less likely to recommend aggressive treatment for Black women and less likely to offer the latest non-invasive treatments for Black women as well. And Black women are less likely to be offered genetic testing for the BRCA1 and BRCA2 genetic mutation. The cancer marker CA125 protein isn't as effective. That test isn't as effective in Black women because Black women tend to have lower levels of that protein circulating in their bloodstream. So I want to point out that research is critical. What becomes evidence depends on who's asking the question and who they're asking. And so sometimes we end up applying a body of evidence to people who had nothing to do with its creation in the first place. And we know how important clinical trial participation is. And about 4% of cancer patients participate in clinical trials. But the number one reason Black women don't participate in clinical trials is because nobody asks them. Their doctors make decisions about what they will and will not do, what their compliance will and will not be, and oftentimes they're simply not offered the opportunity to participate. And when we look at researchers of color, those funded at the highest level by NIH, as well as providers, those percentages of researchers of color haven't changed in 30 years. So there's a lot of things that we don't know. There's no biologic or genetic determinant for race at all. So we have to examine other factors. Epidemiologists will point to delayed childbearing, obesity, less likelihood of breastfeeding, which are all risk factors for breast cancer, as explanations for the difference in mortality rates between Black and white women. But the fact is, we don't really know. Dr. Wender showed some wonderful data. We need to disaggregate that data by race and ethnicity so that we really understand what's going on. So I wanted to highlight a couple of efforts that are helping us get to that. The Black Women's Health Imperative has a partnership with Hologic and Rad Aid to build awareness of breast cancer, cervical cancer screening, and uterine health. And we know that awareness is necessary, but insufficient. So this partnership is designed not only to bring awareness to Black women and women of color about screening, but also to involve women in co-creating what that experience can look like. This project, this study is taking place in FQHCs across the country, where we're going to invite Black women and women of color to tell us, what is it that would get you into screening more regularly, screening earlier? What kind of experience do you want to have with your providers during your screening, diagnostic, and treatment journey? What would it take to create the best experience for you? And we're going to use that data to inform changes in care delivery going forward. The important thing about this project is not only is it involving women, Black women and women of color in co-creation, it guarantees treatment. If women participate in the study and they have an abnormal finding, they will get a diagnostic follow-up. If they have cancer, it will be treated at no cost to them. And the last thing I want to point out is just the Black Women's Health Imperatives Workplace Equity Project. We're looking at the experience of women in the workplace and trying to build on 30 years of research that looks at a causal relationship between experiences of racism and gender discrimination and adverse outcomes and risk for breast cancer. This will be a long time in coming and sort of understanding what that really means in terms of breast cancer outcomes. But in the short term, we're going to find what kinds of programs and practices and policies and experiences need to be in place to change that journey of health and wellness along the way. So stay tuned, check back in 2 years where we'll have some data to report on progress and learnings and how we can improve the health experience for Black women and women of color. Thank you.
Thank you, Linda. That was so helpful. And I know that there'll be a lot of questions coming out of that and incredible information. Our next speaker will be introduced by my fellow congressional spouse, Vera Davis, who is married to Congressman Danny Davis of Illinois, whom the excellent organization we will highlight today. Welcome, Vera.
Hello, everyone. I'm Vera Davis, spouse of Congressman Danny K. Davis of the 7th Congressional District of Illinois. Last December, coming up on a year now, I completed my own treatment for breast cancer. And so today's topic is a very personal one for me. As a longtime member of the Congressional Families Cancer Prevention Program, breast cancer survivor, and as a Black woman, it is my pleasure to be with you today to introduce Paris Thomas, Director of Operations at Equal Hope, a community-based program in my home city of Chicago. Our last speaker did a great job of laying out the disparities Black women face. Now, Paris will tell you about the Equal Hope's impactful work to overcome barriers to prevention, screening, diagnosis, treatment, and survivorship in Illinois. This summer, Equal Hope was awarded a $25,000 grant from the Prevent Cancer Foundation to help expand its current breast and cervical cancer program. We know that detecting breast cancer early is the key to a more favorable treatment outcome. And Equal Hope is making sure that all women, regardless of race or income level, are given an equal chance. So I'm proud to introduce to you Paris Thomas with Equal Hope to tell you about this model program and the important work being done in our Chicago community. Thank you, Paris, for joining us today and the work you do every day to overcome health and disparities and to save lives.
Thank you, Ms. Davis, for that introduction. Equal Hope is a community-based organization in the Chicagoland area who was started over 10 years ago. Equal Hope's mission is to eliminate health disparities in healthcare, particularly around breast cancer and cervical cancer. Equal Hope originally began with the title of the Metropolitan Chicago Breast Cancer Task Force over 10 years ago. As we started, we mapped out 3 programs that were aimed to fight these disparities here in Chicago. The first project is our Outreach, Education, and Patient Navigation Program. Here in the Chicagoland area, we have community-based navigators that are embedded into the community, and they are actually navigating women from the community into the healthcare system. So they're playing both parts. They don't just do a clinical piece, they also do a community-based piece. We also have a quality consortium where we use the data that we compile with different organizations here in the Chicagoland area, specifically hospitals, federally qualified health centers, and other entities to inform the interventions that we put in place. We also then put quality improvement projects in place to improve care around breast cancer. And then we have our grassroots project, which is our advocacy and policy realm, where we are actually doing the work to kind of change laws and policies in place to have equal care for individuals around breast cancer. So Equal Hope's programs, we offer several different things, including free breast screenings, free cervical screenings, medical home placements, or access to a regular care doctor. We have federally qualified health centers that put many women and men on sliding scale fees, and we actually pay those fees to help individuals address the care that they need. We also have quality navigation assistance and tools for prevention, detection, screening awareness, as well as treatment and diagnostic follow-up, and a nurse navigator who follows people all the way through the end of the treatment round. We began over 10 years ago, and basically we looked at the data from 2005 to 2007 and saw that Black women were 62% more likely to die from breast cancer than white women here in the Chicagoland area. When we looked at previous years, this disparity was almost non-prevalent, leading us to confirm that there may be an issue in the quality of care that Black women were receiving here in the Chicagoland area. Also, when we pulled this data, we also looked at other cities similar to Chicago geographically, like New York and San Francisco. And we saw that there were no disparities like there were in Chicago as far as breast cancer. So then this led us into further discovering as to why women had a barrier to care, especially here in the Chicagoland area. So where you live in Chicago matters. So as you can see on this map, the areas in pink are high mortality African-American areas where women are more likely to die from breast cancer. These areas are on the west and south side of Chicago. And where you see a ribbon is where all of the American College breast imaging centers of excellence are located. So then it became a access issue. So if all of these areas have high mortality rates, but yet the breast imaging centers of excellence aren't within your reach for individuals, they aren't accessing that care. So we came up with 3 realms that we felt were basically contributing to this disparity. The first was around access to care. Women weren't able to access the quality care that they needed. They were being put in other facilities and breast cancers were being missed, other things like that were happening. Then there was the actual access to care. So transportation plays a big piece. If these aren't in community centers, women are able to access them. And then there was actually the barriers to care. So this included women having non-insurance or being underinsured and having access. So our program combats these disparities by providing women with free screenings and access to care to quality facilities here in the Chicagoland area. So throughout our work over the last 10 years, we've shown that our approach is working, and Chicago has turned around to be the #1 city in improving breast cancer disparities. We were able to reduce the mortality rate from 62% to 39%. And so that is a big improvement for the Chicagoland area, and we are still fighting this disparity. So over the last 2 years, as COVID has came in and kind of destroyed all of our lives or trying to change our lives, Equal Hope also had to change our model. When the pandemic first started, a lot of our breast centers actually closed, like many other states. And so women weren't able to access the screenings that they needed. A lot of these women had delayed screenings and had, screenings put off because of this. When those centers finally did open later in 2020, many women were hesitant to actually return to these screenings. We had women who felt like they could get COVID if they went into these facilities. There was also a backlog in actual appointments that were actually being made. Since now there's the pandemic, appointments aren't as close and they don't schedule as many women as normally. So most appointments were about 2 to 3 months out. So despite the pandemic rummaging kind of our lives and changing the way that we do our screenings, Equal Hope was able to still provide women access to screenings. We're able to navigate almost close to 2,000 women to breast cancer screenings over the last 2 years, and we were also able to support 35 women as they were diagnosed with breast cancer. We still continued on with our community-based interventions as we were in the community doing canvassing and outreach, and we're able to reach over 83,000 individuals and educate close to 19,000 individuals. So in the midst of COVID happening, Equal Hope also had to adjust our model. And what we did is, as it came to breast cancer and COVID, breast screenings weren't the top priority for everyone. And as I mentioned before, many people were hesitant to return to these facilities. So Equal Hope changed our model to address social services that individuals needed. And we used tools like NowPow and the Hub to basically survey our constituents and our patients to see what kind of services they actually needed. And we use these services to address the care that they needed before providing them the breast screening. So as you can see, a majority of the people that we serve needed financial assistance, additional medical services such as dental work, insurance assistance, employment assistance, support groups, food assistance, and legal assistance. So our navigators went above and beyond by providing these additional services to individuals and then navigating them to partner community-based organizations so they can get their social services addressed in order for them to then be able to go to their breast screenings. So over the next year, Equal Hope will continue to be a leader in the community and work vigorously to expand our reach throughout Chicago. We actually have a campaign right now running that is Cancer Does Not Pause for a Pandemic. As we know, people still need to go out and get the breast screenings that they need or are due for. And we will continue to push this. We're continuing to push education around COVID-19 and encouraging the women in our community to get vaccinated or continue with continual testing. And we're also addressing barriers around COVID-19 so that women don't have a fear when they go back into facilities to get the screenings that they need. In addition to our breast health screenings, we also offer cervical screenings, the medical home placements, and our social needs referrals. So our team is working hard to continue pushing this work forward to combat disparities here in the Chicagoland area. And so if you have any questions or would like to visit Equal Hope and keep up with the work that we're doing, please visit our website at www.equalhope.org or feel free to give us a call to learn more about our initiatives. Thank you so much.
Thank you so much. Thank you so much to all of our speakers for such informative presentations. We'll now move on to the Q&A. Paris was unable to stay with us for the Q&A, but we are joined by her colleague, Donalyn Schaefer, a community outreach worker at Equal Hope. She is busy reaching out to women every day, developing and strengthening relationships between Equal Hope and important leaders, community and faith-based organizations, health institutions, and women's associations. Actually, Donalyn, would you mind just muting for just a second until we're ready, just because there's background wind whenever. Thank you. I also wanted to add a congratulations to Equal Hope, which just last night was awarded the C2 Catalyst Award for, the C2 Catalyst for Equity Award at the Cancer Community Awards presented by AstraZeneca in partnership with Scientific American Custom Media. The C2 Catalyst for Equity Award recognizes those who have worked to overcome longstanding racial and ethnic disparities in cancer care so that all patients have equitable access to quality cancer care. Donalyn, thank you for your work every day and for joining us today. So now—
Thank you so much. I do apologize for the background noise.
Oh, no problem at all. We're excited to hear from you. Before we open up the Q&A, and I have some questions for the panelists, we actually do have results from our poll earlier today. So if we could just share those so we could see what the answers to those questions were. So for polling question number 1, it is definitely interesting to see that 49% people said they did miss or postpone an in-person medical appointment, but they did reschedule it. 21% said have not rescheduled. 19% said they made all their appointments, and 11% said that they have not had any due to the pandemic. So it definitely shows that we do have a total of, doing the quick math, around at least 32% that is still, not, because of the pandemic, not going through. So if we can see the second question. So we can see there, and after Dr. Wender's interesting presentation, we can see how that compares to the information that was shared earlier. I don't know, Dr. Wender, if you're looking at this polling results if you have any thoughts.
Yeah, I think this probably reflects much of how many Americans will look at mammography. I think the majority of women, when presented with the opportunity to start at 40, will choose to start at 40, and it's a good choice. And there are women at higher risk who clearly should start at 40, if not earlier. There are a small group of women who say, listen, I want to just do I don't have a higher risk. I want to do the least exposure to mammography. I'm concerned about having the test. It's uncomfortable. I don't want to have it as more often than I absolutely need to. I don't want to have a recall event where I have to come back for additional views. What's the age where I absolutely have to start? I think 45 is that answer. And it is true, there are guidelines who say that answer is 50, that age where you absolutely have to start. But when I showed that one slide that shows that the 45 to 49 group in terms of risk is very similar to 50 to 54, it's almost impossible to distinguish risk. I think that 45 is the very latest age to start. The majority of women will start at 40.
Interesting. First of all, I really want to encourage people to please, whether or not it's in the chat or in the Q&A feature, please share with us the questions that you might have. We definitely want to make sure that we get them answered. So the first one we had in our Q&A was from Mikey Hoban, said, if my mom died of breast cancer at age 65, at what age should my 38-year-old daughter get her first baseline screening?
So I'll take the first stab at that. I think it's very important to know your family history. And I think if I remember the question, it was the age of what the grandmother, I guess, died of breast cancer. And a critical question to ask your family members is, what age did you develop breast cancer? The age of diagnosis is actually a stronger risk predictor than age of death. A woman could have lived 10 years with the disease, and that means she was diagnosed in her 50s. And that the younger that a woman was diagnosed, the more likely that the family history risk is there. That's number one. Number two, if you have one family member's history, put some work into getting the whole family history. Go out and find out about aunts and grandmothers and all the cancers that people had. Guess what? You have to ask about the men too, because BRCA1 and 2, equal risk of transmission through men, your father or your mother. So the family history is really good to focus on, and we all need to dig into it. Depending on that detailed information, 40 with a family history is probably the latest that I would start is 40, but you might actually find that this is a big family history. A woman might need BRCA1 and 2 testing and might even need to start earlier than 40.
Absolutely. So I want to go to Donalyn for a second. Donalyn, thank you again for joining us. Paris talked about how Equal Hope work changed during the pandemic. Could you talk about your day-to-day outreach work now that we are adjusting to living with COVID in a new way?
Well, I am at one of those events today. We practice social distancing when we're out in the community. When the pandemic in 2020, when it was really at the height, we did a lot of food pantries because we know that's where we would find people in need of medical services. Usually if you're at a food pantry, you probably need some medical services. So that's where I started being a little bit skeptical about being outside doing the stay-at-home order, but people still need to eat. And so we wanted to make sure that not only were we advocating for the screenings, but we're advocating for other social determinants, other things that people may have needed, whether it was getting them food, getting them rental assistance, or mortgage assistance with their mortgage, their lights. And so again, just being in the spaces where we knew people would be.
Got it. Appreciate that. The whole idea of going to where people are and meeting them where they are is, I think, so often undervalued and underprioritized, especially in our healthcare system.
Yes, ma'am. You have to meet people where they're at.
Absolutely. Linda, I'd love to go back to you and some of the things that you had said. It was interesting when you talked about really, one of the things I think, especially with many communities in the Black community, this idea of the diversity within the community and how that can also affect many factors. But I guess just really putting our finger on it, is being a Black woman ever considered a risk factor in and of itself? And how do you feel that really impacts the guidance and the coverage? I mean, I know you talked about just this idea that even within the the testing and all that is going down, just the lack of participation, Black women not being asked to participate, is such a huge factor, which is fairly profound, and that I think frequently either people intentionally or unintentionally just leave people off the table when they're actually doing these tests. But I'd love to hear your thoughts about whether or not really being a Black woman is considered a risk factor in and of itself.
Well, it shouldn't be. As I said, there's no biologic or genetic determinant for race. So that's not a risk factor, but it is a social risk factor. Because the fact is, when a Black woman walks into a provider's office, she can't be sure she's going to get the same quality of care. She can't be sure she's going to get the same recommendations. She can't be sure she's going to be asked the same questions, or if she'll be asked questions about her family history, offered genetic testing. And we see that in the data, because there's no reason for there to be this kind of disparity. We know, for example, if Black woman and a white woman have the same breast cancer, same diagnosis, same treatment, they're going to have the same outcomes. So there's nothing about being Black that should cause this disparity. But there are two issues. The way we talk about data and race and gender sort of leads people to believe, oh, it's because they're Black, and we just sort of accepted that, oh, we have this disparity, Black women die 42% more, well, it's because they're Black. And two, we have not looked at the data closely enough. We don't have disaggregated data. We've got data, but within the data that I talk about, that Dr. Wender talks about, and others, there are differences. And if we could disaggregate the data and look at what is actually happening with Black women, we would see some differences. We would see things that would help explain what we sort of talk about every day in the press and scientific conferences. And most importantly, that then should lead to further research. To your point, Black women are not participating in great numbers in research. There are not great numbers of researchers of color who are even asking the question and wondering about the lived experiences of Black women and what that means for breast cancer or cervical cancer. So we have a lot to do, Lacey. So no, being Black itself is not a risk factor, but it does present barriers because of our lived experience and the history of being Black in this country.
Absolutely. So we have another question now from Leanne Johnson. As a student in public health, I'd like our panelists to explain the difference between mortality and morbidity. It's easy for the lay person to interchange these words. Mortality equals disease, not death. Would love to hear some clarification on that.
I'm happy to go first. When we use the term mortality, we are talking about death, people who die of the disease. Mortality, and we'll often talk about a mortality rate. So it's you have a certain group of people, and it's the percent who die. It gets complicated because we have to do something called age adjusting based on the average age of the population. So you'll often hear this term age adjusted, but I think mortality rate, you count on folks that they've done adequate age adjustment and you can compare those different rates. Morbidity are all the really difficult things that happen to people when they face a disease. And almost every disease entity, chronic illness, has some morbidity. And I think Linda's discussion really highlights that when we think about morbidity, we should think very broadly, not just the physical manifestations of having had radiation or surgery or chemotherapy, but how it's affected your family, your mental health, your social health, your economic health, your ability to be productive. Those are all morbidities, types of morbidity associated with a cancer diagnosis. Linda might want to add something to that.
No, I would say I would agree very much. And we don't tend to look at this And as you know, sometimes women stop treatment or they delay it, and it's because of these morbidity factors that oftentimes their providers just don't quite understand. And I think if we could have a broader understanding of the lived experiences of low-income women and women of color, that might actually influence the kind of treatment that's offered or how that treatment is offered. Instead of treating everybody the same way, we really have to consider, how people's lives are organized so they can make the best use of the treatment and get the best outcome.
I want to give a
Amazing.
shout out
I have a, yeah,
just
please.
to the group in Chicago who has inspired the whole country, because they were number one, as you heard, with the gap between mortality gap between Black women and other groups, and had the largest narrowing of any group. And they outlined a roadmap of a path forward that many other cities are following.
I have about 4 or 5 other questions that I really want to get to in our last 5 minutes. So I'm going to try to push ahead. And want to make sure that we get everybody's questions answered. Mary Himes had asked, I've read that cancer can be in your body for several years before it's visible. Is there research being done to find ways to detect breast cancer earlier? Mammograms don't always pick it up.
It's a wonderful question. It's absolutely true. That cancer begins at the cellular level. We have no way to detect that first few cells. So there is a lot of work going on, both with imaging, particular promise with what's called fast MRI, which we don't have time to go into depth, but it looks very promising, particularly for women with very dense breasts. There are also emerging new blood tests for the detection of cancer that are incredibly interesting. They can detect many different kinds of cancer all in one test. They're early, but we need a lot of research to answer. So yes, a lot of work going on to see if we can do better.
Relatedly, another question: can dense breast tissue only be detected at initial mammogram? 1 in 5 women have misdetected mammograms due to breast tissue, I believe, and require an ultrasound, which costs even more money. Shouldn't ultrasounds be accessible for women who have already have dense breast tissue?
Boy, I'll tell you, it's a really critical question. Having particularly very dense breasts is a risk factor for breast cancer death for 2 reasons. You develop breast cancer more frequently. That is a biological risk of having very dense breasts, but it's also harder to see the breast cancer in mammography. So it's a double dip risk. The most promising test, I believe, for the future is fast MRI, and I think it will outperform ultrasound, although ultrasound is much more widely available, and it adds a little bit to early detection. And you're absolutely right. That initial mammogram gets covered, but frequently the downstream tests do not. Yeah. If you have insurance, it'll cover 80%, but you'll have a copay. For uninsured women, it's a real challenge.
Yeah, and that copay lasts forever. Yeah.
It's very true. I personally went through this myself with having to have an annual mammogram and an ultrasound, and the copays go on and on. Relatedly, could either of you talk a little bit about insurance coverage? Is there a specific set of recommendations insurance companies follow? Is there a workaround if I'm a younger person at risk who wants to get screened? Do I need to get authorization first? I mean, again, you just spoke about yet another issue that is huge, because people talk about mammograms, but then frequently it becomes ultrasound.
Yeah. I'll just jump in and please, Dr. Wender. I mean, part of the issue with the U.S. Preventive Services Task Force recommendations is by statute, insurance companies are going to follow those guidelines when they are implemented. And so if, for example, it was decided that screening mammography should start at 50, then insurance companies are going to cover it. I mean, screening mammography is covered under the ACA with no copay. Insurance companies would cover that, but not under 50. And most women under 50 who might say, I want to get a mammogram, are probably not going to pay for that out of pocket.
Yeah, and Congress did step in for women 40 to 49, and most insurance companies realize what a value this is. So I think coverage nationally, and there's so many different payers, you have to be careful to make a blanket statement. I think coverage for the initial mammogram itself is good. without copays. Pretty broadly, it's those additional tests where it gets more difficult. And under 40, you better check with your insurance company, and there may well be copay.
So, and then I'm just going to do rapid fire because we have to wrap it up. I want to be mindful of everybody's time, but I just want to make sure we get these questions answered. For Marie Royce, I was told by a doctor after mammogram, ultrasound, et cetera, that I needed to have a lumpectomy when I was in my 30s. I had a second opinion mammogram, and I was told I had fibrous tissue and did not have to have a lumpectomy. Can you please share with the group your thoughts on that?
Yeah, it's hard to comment on an individual case, except to say that this isn't that easy, and second opinions matter. So make sure that that you get some information about experience of the center you're getting cared for. Don't hesitate to get a second opinion. That can really help.
Got it. And I have to ask, Dr. Wender, please share evidence-based way to describe alcohol as a cancer risk.
Alcohol is now considered a proven carcinogen, and breast cancer is clearly one of the cancers that is at higher risk. We recommend a maximum of an average of 1 drink a day per woman, and even that little amount does increase breast cancer risk to some extent. So as little alcohol as you can consume, and it's a matter of choice, will keep your risk as low as possible. And for those who have a maximum of a drink a day on average for women, to minimize risk.
Well, thank you. That's all the time we have for questions today. Thank you so much to each of you for such an engaging conversation. And I'll now turn it back over to Lisa McGovern for our call to action.
Can you hear me?
We can hear you.
Great. Thanks so much. Thank you, Lacey, for doing such a beautiful job in moderating this panel. And to our panelists, Linda Goler Blount, who is an expert and so well regarded in all the great work that you're doing, Dr. Wender, our friends at Equal Hope, Vera Davis for introducing. We are so thrilled to have you. I think you can tell by the kinds of questions that we got and the level of engagement how important this topic was, and so we're really grateful. For all the spouses and the congressional staff out there, we hope you'll take this information a step further. First of all, please take care of your own health. If you haven't had your routine screening and you're due for it, now is that time to get to get your appointment back on the books. And you'll find, if you go to the Prevent Cancer Foundation website, you'll find a handy chart to help guide you in that. We also hope that you'll share this information with your constituents and with your loved ones. We've been following up, and we will follow up with our monthly op-eds and our weekly social media posts. So you can share them on Facebook, Instagram, Twitter, and wherever you, however you reach out to your communities. A lot of times you're the people that are on the grounds getting grabbed at the supermarket back home. So we appreciate that you are, you're serving the country with your platforms as well. I also want to make you aware of a great guide that the Prevent Cancer Foundation has, the Breast Health Education Guide for young women. It's recently been updated and is available in English and Spanish, and it is meant to be used in communities to reach young women with information about breast health and breast cancer. The guide was developed to use in interactive group sessions, whether or not it's in person or virtual, and encourage information sharing with female relatives who are age appropriate for screening. We'll send out a link to download to the guide, along with other meeting materials and resources. If you're interested in hard copies, please reach out to us. And again, thank you so much to everyone for joining us for the webinar today. Look in your inboxes for follow-up resources. And if you have questions about this program or ideas for future topics, please don't hesitate to reach out. We are going to be looking to talk about HPV and reaching out in Hispanic communities as well soon. But we look forward to any thoughts you have on great topics for this kind of seminar. And And thank you again for taking time out of a very, very busy day, to our panelists and to all of the people who joined us. We had about 130 registrants, and we're very grateful to have this powerful community engaged today. Thank you so much.